podcasts, and today I'm delighted to be talking to Anthony. I'm John Brewin, Chief Exec of Knots Healthcare. Anthony, do you want to introduce yourself and your role?
So Anthony Maher, I'm a clinical lead and consultant podiatric surgeon for the podiatric surgery service based out of Park House in Carlton, and also more recently the Newark team based at Newark Hospital.
Great. Not many people know exactly what podiatry is all about. I had the opportunity to visit you as part of the induction last year, and was really impressed by the setup that you've got down there, the professionalism of everybody involved, and the sheer scope and scale of what you were doing. And it's brilliant that our organisation can host that and develop these services for patients. But I just wondered whether you could give us a sort of a thumbnail summary of the sorts of things that you and your team get involved in.
So podiatry as a whole covers foot health for the whole of Nottinghamshire, and there are various sort of levels of podiatry provision. So we have the core podiatry service that will provide routine foot care for those at risk of ulceration or disability, and typically looking at patients with sort of diabetes or vascular problems. We also have our musculoskeletal podiatrists who deal with mechanical related foot and lower limb pain, and they'll provide orthotics and steroid injection type therapies at sites across Nottinghamshire. Then we have our advanced podiatry teams. We have diabetes podiatrists based at NUH and also at Kingsmill, working with the diabetes doctors and the vascular surgeons there. And they're really looking at minimising amputations which can occur as a result of ulceration. And then finally, we have the podiatric surgery team. Two podiatric surgery teams. We have our team at Park House and a second team over at Newark, and we also have satellite clinics in Retford and Mansfield. So the podiatric surgery team offers elective foot surgery for chronic foot pain and deformity. So the sorts of conditions that we would treat, typically bunions or hallux valgus, hammer-toes, arthritis of the foot, soft tissue lumps and bumps, nerve entrapments, pretty much anything, any elective chronic problem that might occur with the foot that isn't an acute sort of trauma. So those trauma patients would go to NUH and would be managed by our orthopaedic colleagues.
Yeah. Great. That's a great summary. Thank you. So I can imagine that there's a massive amount of demand out there across the county, and particularly if a lot of it's is elective work. The effects of the pandemic must have been pretty immense across your service.
So huge, really. I mean, in late March, we had the directive from NHS England to stop all routine elective surgery, across the NHS. So our last operating list was in first week in April, and it was challenging cancelling those patients. And we do get to know the patients in our kind of work up to surgery, and often we run through conservative treatments with them, so we'll offer steroid injections and so forth. So really surgery is the end of the line, and it's the end of the line for patients with really quite chronic and profound, painful foot and ankle conditions. So often by the time the patient will make the decision for surgery and we agree to those procedures, they are in an awful lot of pain. It's having a real impact on their quality of life and their daily activities. About 60 to 70% of our patients are working, and often those patients are in occupations which will involve prolonged periods of standing and walking. That's always a contributory factor. So to cancel those patients, it was heartbreaking, and to cancel them with no end in sight. And I think that at the time it felt difficult to cancel those surgeries, but actually that's probably one of the easiest things that we've done over the last several months. Trying to then rebuild the service in a safe, sort of COVID compliant way has been really challenging, and we've had to work with partners in NUH and the microbiology teams to find safe ways of testing and screening our patients. We've had to look to guidance from the Royal Colleges and professional bodies, which initially was rather limited, but as the weeks and months have gone by, both nationally and internationally, really strong guidance has come in, and supported as well by NHS England. But that said, it has taken through to the beginning of October to restart our service. So whereas our patients were waiting a maximum of 17 weeks for an operation, so we were always inside the 18-week pathway, we're now looking at probably close to a year to get through to surgery. So yeah, big pressures and big problems ahead, and of course much longer waits for patients with painful foot complaints.
So I mean, and it's probably too early to know, but the impact of the tier 3 and as wave 2 really hits us hard, are you looking at having to sort of perhaps step things down again, or are you not got to that point yet?
I think one of the real strengths of Park House as it is at the moment is that we can operate as a green site or a cold site, so we can be free from COVID. We're testing our patients 3 days before their surgeries. So as long as our staff remain fit and healthy, which is another big risk, we should be able to continue. Now, when NHS England stopped elective surgeries in March, it was because of the concern of requiring the intensive care beds. Now, it's highly unlikely the podiatric surgery patients would require an intensive care bed. I mean, it's extremely unlikely that they would have to be admitted to hospital. It's not impossible, because complications do occur, but for the vast majority, it would be highly unusual for someone. So on that basis, I think that we are, free to continue offering elective foot surgery, during the pandemic to those patients who have been waiting an awfully long time already. Whereas our colleagues working in the acute trusts who are reliant on, inpatient beds, they're facing many more challenges. So I think we have a real opportunity in podiatric surgery to keep going and to continue looking after our patients, during this period.
Yeah, great. And more broadly, Anthony, how are the team doing? How's sort of staff morale and having to cope with the challenges that we're all faced with in recent times?
I think in the first few months of lockdown, there was a real lack of redeployment. So overnight, the service stopped. We had a few consultations to finish up, and once they were done, there was very little work initially, and we were willing and able to be redeployed, but only a handful were ever redeployed. So I think there was a feeling in the team of being sort of undervalued. Now that was a problem early on, but I think that as we then started building on our plans to get the service going again, there's been a lot of positivity around that. I mean, one thing we did early on actually is we embraced telephone consultations, and that was a turning point for the service, because I had been anti-telephone conversations for all of my sort of 20 years in the profession, if I'm honest. And you know what, they really do work. So we have managed to keep an eye on our patients. So obviously we don't want to just leave patients waiting for long periods without contact. So we have been checking in and ensuring that patients aren't deteriorating, and where they are, we've been intervening. Video consultations, we did some work on video consultations, and I think there's still work to be done there, particularly on the technology. And now I think video consultations work very well for I suppose, talking therapies.
Right.
I think maybe less so where we're looking at physical examination of the foot. Ultimately, I can't palpate the foot. I can't test the range of motion over a video consultation. I think that the process that we've come up with, I mean, we are triaging all of our patients by telephone, and that means that we can get through a lot of the questioning over the phone, which in turn means that we can minimize time in the clinic. We're still calling patients into clinic for that final sort of clinical examination of the foot, but we're doing that having already taken a detailed history and having already worked up towards, we're very much approaching a diagnosis, approaching a treatment plan, and really we're putting in place that sort of confirmatory, visit, and that seems to be working really well. With telephone consultations also working well for follow-ups. So following intervention, actually we can do an awful lot of that by telephone. So yeah, it's revolutionized the way that we work, and I think that's something that we will stick with.
Yeah, I think that's been an equivalent learning right across the piece, hasn't it? Really, that and I similarly had sort of a lot of preconceptions about the downside of either telephone or video consultations. It's not the real thing, is it? But I think there's been a massive amount of learning. The technology has been really enabling, and there are lots of benefits that I think we'll take forward after the pandemic. We'll sort of embed across our services to suit our future needs. I think it's one of the bright spots of difficult times.
Yeah, I think we had an issue early on with the lack of equipment, so lack of access to mobile phones. Sorry, that's my mobile phone ringing. So lack of access to phones, lack of laptops and so forth. That was a real problem for the team, so they weren't able to connect in. But now we are all fully equipped, and so we've made really good use of Microsoft Teams. So we have a monthly, clinical supervision team meeting. We haven't actually held a face-to-face meeting with the whole team since it will be February. Yeah. But we are doing them regularly with teams, and during the working day we can check in with one another via Teams as well. And actually I think we've all adapted to that, and it's not quite the same, is it, as being in the room, but it's not bad. I think it is definitely making the best of a bad situation.
Yeah, no, I completely agree. It's those it's more informal things, isn't it? It's sort of popping your head around the door with a cup of coffee and having a bit of a chat. You don't do that so much on Teams, but yeah. It's the technology is really impressive, and has helped massively. Where we'd be without it, I'm not sure. Good stuff. Before we finish, anything else particularly wanted to ask or say about?
I suppose one of the concerns that the podiatry service as a whole, and not just the sort of specialist teams, was around the redeployment. And I suppose that as we're approaching this second wave, and we don't know, I suppose, just how bad that's going to get and whether it will impact on the routine services. I think there was probably a failure to fully appreciate the range of skills that podiatrists have. Not necessarily all podiatrists, but certainly some in the team have quite advanced skills that could be maybe better used if in terms of redeployment. And certainly looking around the UK, and I suppose it varies depending on the employing organisation, but where podiatrists were working in the acute trusts, I think they were more readily redeployed. But I suppose there was also more demand within those acute trusts in that first wave of the pandemic. So perhaps there's some work to be done around how if we were to look at redeployment in the future, would that be at a sort of ICS level perhaps, to perhaps maximise on the skills that people have available.
I think that's a really good point. I think first time around, we did a lot of things in sort of blanket way, didn't we, in terms of stepping down and redeploying without perhaps thinking more broadly about exactly the point you've just made. I agree. I think if we do get to that point, which fingers crossed we don't get to, but we know that the rates in Nottingham have been very high and perhaps flattening out a bit now. But I think a broader view of where people could be redeployed to match their skills with what's available. I agree. I think it would be good if we could look more broadly at that, so that people don't feel undervalued or neglected, as you put it. I think it's a really well-made point, Anthony. I'll pick that up with the executive team.
I suppose the flip side of that is that our sort of chronic painful complaint type patients that do need that kind of regular impact. I think maybe some of them were neglected, I guess, to some extent when we shut down all of those services very quickly, and that was the right thing to do. But I suppose we also need a mechanism to make sure that we're still looking after those patients at greatest need. But I think that applies to all services, doesn't it? Absolutely,
yeah. Great, good stuff. My clock says 24 minutes in, so I think
okay, yeah.
we've got a good stack of stuff there.